We got a lot to cover. We'll cover hips, knees, and then I got a couple slides at the end on shoulders. So one of the things we're going to talk about is, a question for everybody. Nobody's banging down the door to get in for a hip or knee replacement. Surgery is kind of the last option. So some of the regenerative biologic treatments, we'll kind of talk about those. And there's different ones that you can use, whether donated tissue or your own tissue, or growth factors from your blood. That's platelet-rich plasma. We'll talk about that. If all the biologic stuff fails, we'll go over what actually happens during surgery, how we do the surgery, what approaches you use to get to the hip and knee and shoulder. So we'll kind of go over all that as far as robotics and anterior hip and then reverse total shoulder. So I'm Dr. Eichten, board certified orthopedic surgeon. I've been in Fort Myers, Naples area since 2012, which seems like a long time ago now. But I did do a fellowship in just hip, knee, and shoulder replacement. So that's kind of an extra year of training after you get done with your residency in orthopedics. And that kind of goes, from a fellowship standpoint, most residents that graduate are going into some subspecialty, whether it be hand or shoulder or spine. So there's different subspecialties after you do your general orthopedics. I chose hip and knee replacement. The fellowship helps you get more experience in that first year. You definitely don't get the orthopedic surgeon pay, so that's the downside, but having a career where the patients are happy is the upside. So University of St. Thomas, where I did my undergrad, and then I keep moving further and further south, Kansas City, Ohio, now Florida. Now, this is the campus at St. Thomas, so it's not the campus on the island. So it's definitely snow. That's up in Minnesota, St. Paul, Minnesota. So it's a great school, but keep moving further and further south. Now, the lakes in Minnesota, the only thing that can hurt you is probably a snapping turtle. So you got to be a little bit more careful swimming down here with the gators. And there's no ice fishing down here. Physicians Regional North used to be called Landmark, but Physicians Regional bought it. That's by our Naples office. So if we're in Naples, that's where we can operate. And then Lee Memorial's they shifted a lot of the trauma to Gulf Coast. So now we're doing cases at Lee Memorial. And then the building that you're in is our Performance Health Surgery Center. So we do majority of our cases here as long as the patients are healthy, don't have any significant medical problems or have to go to the hospital. So most of them are done outpatient now. We do have 3 offices now, one in Fort Myers, one in Naples, and one in Cape Coral. So a lot of the joint replacement statistics, they see a big increase with the baby boomer population. So the goal is kind of to get them done correctly the first time so that they last the longest, because the hip and knee surgeons are going to have to do all the revisions. So we're trying to limit that. And then the other side to that is, can we limit the amount of people getting the replacements? And that's where the biologic stuff comes in. So definitely a huge increase in demand over the next 10 years. So as I explained before with the fellowship, you do have better outcomes because you're more high volume. And that's basically all we do now is hip, knees, and shoulders. So you get better outcomes, more cases, and lower complications with somebody who's fellowship trained in joint replacement. So what is arthritis? Most commonly, we're talking about osteoarthritis. That's kind of what we call the wear and tear arthritis. That's kind of a slow degeneration of the joints. Rheumatoid arthritis is more inflammatory. That's your body kind of attacking itself. And that can affect multiple joints. Some people have osteoarthritis, it's just one joint. Rheumatoid is more than one joint. And then post-traumatic, some people had a fracture when they were in college or trauma, or they tore their ACL. Those people can get post-traumatic arthritis. The symptoms can come on suddenly, or it can be more gradual. A lot of people, when it comes to the knee, they feel like it's giving out, locking or buckling. You do get stiffness. You can get swelling in the joint. That's called an effusion. And I put grumpy up there because a lot of times the spouses will say that, the pain's kind of affecting their personality. So we do see that too. So the goal is kind of get rid of the pain, keep you active. When we see patients in the office, we're kind of checking everything, how they walk, is there a deformity, how much swelling there is. That term crepitus is kind of the crunching in the joint. So if the cartilage is not smooth, it'll make noise there. And what we're looking at is the white stuff. So that's the cartilage covering the knee. So every joint is covered. The bone is covered with cartilage. It makes it smooth, and it lasts a long time. The picture on the right, you can see the cartilage is worn out. That's what we call osteoarthritis. So we're not talking about the ligaments. We're not talking about the meniscus. We're talking about the articular cartilage. Now, some of the confusion with joint replacement or knee replacement especially, some people think we're cutting out the whole knee and putting in some fancy, robotic knee that's going to bend and everything. All we're doing is covering the end of the bone. So think of the cartilage that's worn out. We're just going to cover that. So instead of cartilage, you have metal and plastic. So the metal and plastic obviously feels a little bit different, but we try to keep as much tissue of your own to put less stress on the implant. So we do have revision implants where the parts kind of lock together, but if we do that, then the parts wear out quicker. So the more we use your tissue, your muscles to stabilize it, the longer the implants are going to last. So you can see the cartilage is a very thin layer. It gets its nutrition from the joint fluid. So there's not a great blood supply to the cartilage, and that's why we think that the reason your body doesn't just heal the cartilage when you have arthritis is because there's no blood supply to send in the stem cells. So when we talk about stem cells, we're trying to become the blood flow, get the stem cells in the joint to help it heal. And some of the drug companies, if you look at the actual protein, the cartilage proteins, that hyaluronic acid, it's one of the proteins. That's one of the injections that you can do. It's called a gel injection. And then x-rays. So the cartilage does not show up on a plain film x-ray. So what you want to see is space. So if there's space there, then you assume that the cartilage is still there. Now, occasionally we'll get an MRI where there's a little cartilage defect if the x-ray looks normal. But you can see if the cartilage is completely worn out, the bone's touching. So my job's pretty easy when it's like this. It's pretty obvious what the problem is. The bone's touching, that's where your pain's coming from. Now, if the bone's touching, that puts more pressure on the bone responds to pressure just like it would a fracture, and it grows more bone. So when people talk about their bone spurs, that's what they're talking about. If you get rid of the bone spurs, you still have the cartilage problem, and they're just going to regrow. So that's a common question that we get too. So you'll see that joint space narrowing. The bone can get a little bit whiter on the x-ray. That just means it's harder because it's taking more stress. And then we also see cysts as well. Now, as far as the hip arthritis, the hip pain is typically in the groin. It can radiate to the knee. That's usually in the front of the hip. So when we see patients that complain of buttock pain, it could be the sacroiliac joint, or it could be a pinched nerve in the back. And we see that a lot because we're trying to figure out, is it hip, is it back? If you have pain directly on the outside part of the hip, that could be just hip bursitis. So that's a lot better than having arthritis. You just inject the bursitis and it goes away. When you talk about knee arthritis, it's pretty clear cut. People point to their knee. It doesn't go up and down the leg typically. So hip can be a little bit more confusing. So sometimes we have to get an MRI of the hip and the back. It's not confusing when it looks like this. There's no space there. It's obvious that the hip's bone on bone. And that's the picture on the right. So when we talk about non-surgical treatment, there's a lot of different things that you'll see online. There's a lot of different things that you can do. If they work and they don't cost a lot of money or they're effective, then you can keep doing it. You don't have to have a knee replacement or a hip replacement, depending on what your x-rays look like, as long as you don't have pain. So the non-surgical treatment, sometimes, a patient will say, my neighbor did this and it worked really good. It depends on what the neighbor's x-rays look like. If the x-rays are, severe bone on bone, whatever you inject, whatever you do, stem cells or whatnot, it may not work as good because depending on what their x-rays look like. So if the arthritis is not as bad, there's a lot more stuff that works good. If you can get rid of the pain and keep doing the activities that you like to do, you don't have to rush to a replacement. The replacement's kind of last resort. Now, there's a downside to waiting too long, too. If you're super weak or you can barely walk or you're super stiff, that's going to be harder for your recovery. So just keep that in mind as well. So a lot of people will change their activities. A lot of people that were long-distance runners, they get arthritis. They could switch to bicycling or swimming. That's a little bit easier on the joints, and you can kind of keep going like that. The benefits of getting, exercise and being healthy kind of outweigh the risks of making the arthritis worse. We do physical therapy a lot. That'll help strengthen the muscles around the joint, and that kind of takes pressure off that cartilage that's worn out. So that does help. When it gets to the point where you have a deformity, or it's very painful to walk, some people will use a cane. You can use a walker. Nobody loves to use those, but they do take pressure off the joints. There's a couple braces, especially for the knees, that can kind of unload the joint, kind of take pressure off. They're kind of expensive. Some people don't like wearing them because they're kind of big and bulky, but it is an option. And as you see in the picture, the cane can help with the self-defense weapon too if you need it. You never know. So the medications. So oral medications is kind of the first line. Tylenol, Advil, Aleve. If you're talking about supplements, turmeric is an anti-inflammatory too. They decrease the swelling, decrease the pain. Some patients have to be careful. If you have liver problems, then we kind of steer away from the Tylenol. If you have kidney problems or stomach ulcers, then your doctor will tell you not to take the Advil or the Aleve. We have some that are a little bit easier on the stomach. That would be Mobic or Celebrex. Those don't affect the stomach lining as much as the Aleve and Advil. So we have options for that. And typically, if you need to be on it every day, that's fine. You just got to keep the doses, and you got to make sure you're checking your kidneys as far as those go. The anti-inflammatories are more of a as needed. So if you have pain, take them. If you don't have pain, don't take them. And then some of the oral supplements, we talked about turmeric, but there's glucosamine, chondroitin. There's a lot of collagen supplements now that may help. When they looked at, the bigger studies, like 50,000 people, they couldn't really find a huge difference between placebo and the supplements. So I usually tell people if you want to try it for a month or two, it's not a lot of downside. It's either going to work or it's not going to work. If it works, then you can keep taking it. If it doesn't work, then kind of stop it. So what we do in the office, there's injections. The one we do most commonly, is covered by all the insurances, is steroid injection. It's an anti-inflammatory. So instead of taking the pills, you're just putting the anti-inflammatory directly into the joint that's hurting you. That does relieve the swelling. It does help with pain. The question is, how long is it going to last? So we sometimes do a cortisone shot. It could last a couple of years. That's usually a patient that doesn't have severe arthritis. If you have severe arthritis, some of those patients come in every 3 months. You don't really want to do more than 4 per joint because it can weaken the tissue around the joint. There's a couple studies that say it can worsen the arthritis as well. So a lot of people that were using the steroids on, the cartilage is already gone. You're not going to make it worse. And then you can kind of do those to maintain for every 3 months. Now, the other thing that patients ask, let me try a cortisone. Okay, it only lasted a couple weeks or a month. Now I want to do my knee surgery or hip surgery. The literature says that you need to wait 3 months before doing the surgery just because it increases your risk of infection. So when they looked at people that had infections, a lot of them had a cortisone shot a couple weeks before surgery. So that's important. Any shot we do, it's usually 3 months, either gel or cortisone. So that depends on the timing too. The other injection would be gel. That's hyaluronic acid. So you're basically taking those cartilage proteins that we talked about, and you can inject that into the joint. Medicare does approve those every 6 months. So they help kind of lubricate the joint, decrease the inflammation. A lot of the commercial insurances stop paying for them because there's a couple studies that say it's no different than the cortisone. But we do have patients where the cortisone didn't work, the gel worked. So there's definitely options. And then getting into more of the regenerative stuff, platelet-rich plasma is your own blood. So you're taking growth factors from your blood and you're injecting it, and you're trying to prevent the cartilage from getting worse. There's technically no stem cells in the PRP. Stem cells are the cells that can turn into different tissue. So you want it to turn into a cartilage tissue. So we'll talk about that. The platelet-rich plasma injections, there's a couple of studies. We've used it a lot for tendons or tennis elbow. Now we're starting to use it a little bit more for arthritis. And 70% of the patients that took it, when they compared the MRIs, had no worsening of the arthritis. So 30% still kind of worsened. So that's kind of your odds with the PRP, at least from this study. So the PRP injections are working better than the cortisone, and sometimes they last longer. The issue is insurance does not cover them yet. So that's the issue. But this is what it looks like. Basically, you take a small amount of blood, we spin it down in a centrifuge machine, and that separates out the layers. So you're getting rid of the red blood cells. You're just taking the platelet layer, which is kind of the yellow. And that's what you inject into the joint. And you can use it for anything. You can use it for rotator cuff tears. You can use it for hip, knee, shoulder. So we do a lot of these injections in the office. Takes 20, 30 minutes to do it, but that is a good option. Now, stem cells, the stem cell line that we're talking about, mesenchymal stem cell, some people just switch that to musculoskeletal because it's a little bit easier for people to understand. Those can turn into 4 different cell lines. So it's either bone, muscle, cartilage, or fat. So theoretically, you can take the stem cells from any of those areas and inject them somewhere else. The body will pick up the signals depending on where you inject it. So if you inject it into a hurt muscle, it can help heal the muscle. Now, the difference between the muscle and the cartilage is important to remember. The muscle has blood supply. So if you tear your muscle, your body's going to heal it because the stem cells get released and they heal the muscle. The cartilage does not have the blood supply. So by injecting it, we're trying to become the blood vessels to get the stem cells in there. So you can get it from your own fat tissue. You can get it from your own bone marrow. You can also get it from donated tissues. So when they ask mothers about, do you want to keep your placenta or your umbilical cord, that's where these companies are getting them. So they're tested pretty strenuously, just like it would a transfusion. So one of the ones we use is called JuviXO. That's from the mesenchymal stem cells that we talked about. And there's a lot of different growth factors in these that can help maintain the cartilage, possibly regrow the cartilage. Now, all this is experimental, so that's why the insurances don't cover it, but there are plenty of options as far as what you use. Now, the donated tissue or the amniotic tissue, it's hard to get. The FDA is pretty strict on it. These exosomes are approved for skin use, so it's off-label to inject them into the joint, but a lot of people are doing it, and it works very good. And again, it depends on how bad the arthritis is as well. So what got me interested in the stem cells, there's a couple articles. I'll just show you a bigger picture here. They took fat cells from the patient, injected them, and you can see after 6 months, that's the 6M, the cartilage regrew. So it's definitely the concept has been proven. We just don't know why. Some people it works great, some people it doesn't work. And then when you talk about looking at it under a microscope, it was real cartilage, it wasn't scar tissue. So the proof of the stem cells turning into cartilage tissue, we know it can happen. We just try to be selective on which patients it may or may not work. Typically right now, if you're bone on bone, but you still have decent alignment, you could still try it. If you start to get, deformities like you're 10 degrees, those patients, it doesn't really work very well. So we'll tell you in the office based off your MRI or x-rays what your, chances are. Now, you can get it from the bone as well, and sometimes we'll do that either from the femur tibia or the iliac crest. And you can also get it from your fat tissue. So it's a little bit easier to get it from your fat tissue, and that's the one we use most commonly in the office. That's called lipogems. And the reason for that, as well as people age, the number of stem cells in our bone marrow kind of decreases. We don't see that with the fat. So there's studies that there's 500 times more stem cells in the fat tissue compared to the equivalent amount of bone marrow. Now, the lipogem is pretty simple. We do the fat, we get it from your flank, we put it through their filter system, and then we just inject the fat with the stem cells. So that's what goes back into the knee. Now, because you're using your own tissue and you're doing it on the same day, you're not freezing it, the FDA has approved the fat transfer, tissue transfer. So it's been approved as because you're using the same patient, same day, you're not storing it, you're not adding any other things to it, then it would be considered a new drug and they have to reapply for approval. So they've been using this in multiple different areas as well, depending on what field people are in, urology, neurosurgery, just depends on where you need the stem cells to go. So that's kind of what it looks like under the microscope. Now, sometimes you get frozen stem cells. The stem cell may not be alive, but the exosomes and the stuff on the outside are what kind of helps with the growth factors. They believe the stem cells with the fat tissue kind of protects them. So if you're injecting it through a needle, you're not going to damage any of the stem cells. That's what it looks like under the microscope. And the good thing is it has everything you need. It has the stem cells, it has the scaffolding and the growth factors that helps with the regeneration of the tissue. So it's pretty straightforward. We do it in the office. We just use lidocaine. You don't need any general anesthesia or anything. And we basically take it from the flank. We numb the skin, make a small poke hole. We numb the fat. We wait, 20 minutes or so, and then kind of get the fat out. Then we clean it through the system. That gets rid of any of the toxins or blood cells, etc. And then you're just left with that high concentration of the stem cells, which is what you want. And a couple of the studies showed, like I said before, 500 times more stem cells per the fat compared to the bone marrow. So that's why we use that one more commonly. Now, what do the studies show? It's less invasive than taking it from the bone. Some people have a little bit of bone pain if you take it from the iliac crest. There's also more stem cells. So a lot of the places that are using it, kind of the big universities, I flew up to Emory to kind of learn how to do it. So hopefully we're getting some more studies coming up. Now, Dr. Tremolata is a plastic surgeon. He's the one that kind of developed that cleaning system. And he developed it to inject people's faces with fat, to kind of get rid of wrinkles. And he said, the fat I'm getting is just too thick, it's too bulky. So that's why he did that, filter system to kind of make it smaller. Now, when they inject fat, they usually have to redo it every 6 months or a year because the fat kind of atrophies. When he cleaned it, started doing the fat into the face, they were saying that the wrinkles were kind of going away more permanently. So that's when they, sent it to the lab. So there's a ton of stem cells in there. That's why it's working and the fat's not atrophying. So that's kind of where it came from. And since then, it's kind of been pushed into other fields. So this is kind of we basically just use saline to kind of clean it. That's what it looks like under the electron microscope. They're definitely winning awards for the newest technology in sports medicine. Some of the case presentations that they reported, you can see the picture on the left is the MRI. So there's a cyst and then missing cartilage there. And you can see it's a little bit thicker on the right side. That's new cartilage that's grown, and that's on an MRI. So same with the pictures. This patient is bone on bone, but they're relatively straight. They don't have a huge deformity. And you can see there's a little bit of growth of the cartilage. Here's some of our patients. It usually takes about 6 months for the stem cells to regrow. So that patient on the right has a little bit more space there. Their pain's gone. It's bought them some time. It doesn't completely reverse the arthritis back to normal. But we have some patients that are 8 years out now that haven't had another injection. So this patient had a lot of what we call that crepitus or crunching under the kneecap. We did the stem cells 6 months later. They had more space and the crunching was gone. And this patient was able to hike in Europe without any pain. Again, there's minimal improvement in that space, but it does last for a while. I think this is our first patient that's probably 8 or 9 years out now on the far left. From a treatment standpoint, when we saw him for his knees, he had moderate arthritis. So it wasn't normal and it wasn't bone on bone. So I think the patients that have moderate arthritis do a lot better than if you're completely bone on bone. So he's come back not for the knees, but for his shoulders and his ankles. So we did that more recently. So some of the studies right now, they're currently in process. So they're not completed because you have to enroll a bunch of patients. Then you have to follow them for 2 years. To get all that information, it takes years to kind of get a good double-blinded study, meaning the treatment group and the doctor does not know which one the patient had. So when they compare the fat to cortisone, that's going to be, at least 100 patients. They're also comparing it to the gel. So these are some of the studies that aren't completed yet. They're doing it in Italy as well, where Dr. Tremolata is from. They're comparing it to PRP. So we get more studies, theoretically, if we get more studies that it works better, maybe the insurance will cover it at some point. Currently, it's $3,500 to do that. Usually get enough to do 2 joints. So $3,500 covers both knees or both hips. Now, some of the other studies that are out with a small number of patients, these patients, they did pretty much bone-on-bone arthritis, but they were too sick to do surgery, so they did on them. They were all better at 6 weeks, 6 months, and 12 months. So they had significant improvement. The other thing is there was no significant adverse events. So most people have a little bit of pain at the site where you take the fat, and then it takes a little bit longer, whether you're talking about the lipogems or you're talking about the PRP, for those things to kind of kick in. So you're looking at about 6 to 8 weeks for it to start working. We do limit your activity for the first 2 weeks after, because we want everything to kind of get set up. And then once it sets up, those stem cells will start releasing the growth factors. So that's a lot of non-surgical treatment. When that fails, or if you have a severe deformity, you may be better off just going right to the replacement. But we do try as much as we can pre-replacement. Now, there is arthroscopic surgery. There's also different cartilage preservation. And a lot of that depends on how big the defect is. So if you have a smaller defect, you can do a knee arthroscopy. And basically, this is called a microfracture. On that bottom left, you're poking holes in your own bone. You're trying to get bone marrow to kind of fill in the defect. That's something that you can do short of replacement. The arthroscopies are very good for meniscus tears, but if you have both, sometimes we trim out the meniscus and the arthritis gets worse. So it's kind of case by case if somebody's going to get better with a knee arthroscopy. When I was in residency a couple years back, we used to do a lot of knee scopes. So if you had an MRI in your MRI, 15 years ago, 20 years ago, we scoped your knee. We called it a clean out. Yes, you have arthritis, but I don't want replacement. Let's just scope it. Those patients don't get better, and that's what the literature's kind of shown. So over time, orthopedic surgeons are doing less and less knee arthroscopies depending on how bad the arthritis is. If you just have a meniscus tear, the knee arthroscopy works very good. Now, if you can't do a microfracture and the defect is small, you can do what's called an Oates graft or osteochondral grafting. You're basically stealing the bone with the cartilage and putting a plug in there. So the bone will heal behind the cartilage. That has blood supply, that'll heal. So when you're talking about replacement, like we said before, you're covering the end of the bone, you're covering the cartilage. So the goals of replacement, you're trying to get the patient back to the stuff they like to do. So that's either usually golf or tennis, but I did add the pickleball because that's very popular right now. Now, on the x-ray, you used to see the cartilage. The cartilage would be the space. Now the space is the polyethylene, so that's the plastic. That's what it looks like post-operatively. So, when we talk about how do we get to the knee, we try over time. We've gotten better and better at not cutting muscles and tendons because those cause more pain. You still have the bone pain, but we try to preserve as much as we can. Minimally invasive total knee has to do with, one, the incision, but also the muscles and what you do underneath the skin. So we try to preserve the quadriceps. So traditionally, people would cut right through the middle of the quad. But we're trying to preserve the quad tendon. That's called the subvastus approach, which I'll show you a picture of that. Excuse me. So, and then with the newer technologies, we're putting them in better position. That's the precision you get with the robotics, which we'll go over. So a traditional medial parapatellar approach is what it's called. You go around the patella and you go straight up the quad tendon. Now you have to repair the quad tendon at the end. Some people get pain there. You get a little bit of weakness. So we're trying to avoid that. So when you talk about subvastus, if you look at that black line, you're sneaking around all of the quad muscles and tendons. That's called the vastus muscle. So you're going underneath the vastus muscle, and then you pull the entire quad mechanism over to the side. That's called the subvastus approach. It's been around for a long time. If you're good at advertising, you add a slogan to it, which is called the Jiffy Knee. That's the same approach that we use, but they just added, advertising and called it the Jiffy Knee. That's what they're talking about, is not cutting the quad. So it's quadriceps sparing. It does very well as far as the post-op recovery. You still have the surgical pain. You still cut specific, the 30-year knee, the get-around knee. That's all advertising from the companies. Most of the big companies are very good. Some of them source the polyethylenes from the same companies. So you want what your surgeon's comfortable with. Now, a lot of the custom stuff we don't do as much anymore because of the robotics, but those are available. The custom stuff, you had to get a CT scan or MRI beforehand. We don't have to do that with the robot. We can just do it with x-rays. And I'll kind of show you that. So some of the stuff we do, some of it we don't do. The 30-year knee has not been in a human being for 30 years, but they cycled it so many times in the lab. So some of that stuff does not matter as much. You want it put in correctly. You know, you want, like I said, the joint replacement specialist that does a lot of them. Now, the newest stuff that's come out recently, they used to try to do the total knees without cement. So those are called press fit. So those are coming back around. You can see there's a rough surface similar to the total hip where the bone can grow onto the implant. Now, we know from some of the studies that the polyethylenes or plastics that we're using are lasting a lot longer than they used to. So we're trying to get to 40 years. So somebody in their 50s or 60s, it can last the rest of their life. Some of that could be an issue with the cement, because if the cement breaks down over time, you know, that's why the press fits are getting more popular. Depending on the patient's age and bone quality, the gold standard is still cement. The cement will stick to the bone and will stick to the metal on the tibia and the femur, and then you put the polyethylene in the way. So it's the same concept. It's just a matter of getting the bone to stick to the metal or the cement to stick to the metal and the bone. There's always a less than 1% chance that either the bone doesn't grow onto the metal or the cement doesn't stick to the metal. So that's very rare, but we do see that. So depending on the patient's age and bone quality, that's a newer option with the press fit. Now, we talked a little bit about the custom. Takes a little bit longer to get them, and we don't really need to do that with the newer robotic technology. Now, previously with computer navigation knees, and I did them, 15, 20 years ago in residency, it was only looking at the patient's hip, knee, and ankle and checking the alignment. So it's doing the bony alignment, same with the CAT scan or MRIs. They're only checking your alignment based off of that. They're not checking your alignment based off your soft tissue. So the soft tissue is very important with joint replacement. If you're tight on one side and loose on the other side, the computer navigation or the custom stuff does not take that into consideration. With the robotic surgery, and the reason I switched completely to robotics is it adds in the soft tissue balancing at the same time. So you're getting both the bone and the soft tissue balancing at the same time. And I'll show you pictures of that. The one I use is the ROSA. That's Zimmer Biomet. It does give you the feedback on your tension. Before, if you do a manual knee, it's like, yeah, it feels good. Now I know based off the numbers that we're perfectly balanced, and I could feel comfortable leaving the operating room. Patient could feel comfortable. We probably released a little less soft tissue, so that helps with recovery. I think patients are moving quicker. They're getting their range of motion quicker. And it's very accurate. So we can cut. Sometimes we would cut with the manual knee, and it feels loose on one side, so we'd have to recut. You don't really have to recut with the robotics. The cut we make is accurate, and we don't have to change. So basically, you can do the surgery on the computer screen before making any cuts on the patient. Before we would do the manual, we'd cut, and then, okay, it's a little loose. We got to adjust a little bit here, release a little bit of soft tissue. Now we can do it all at once. So in the operating room, you can see there's a camera on the right that kind of senses where the trackers are. So we do have to put pins in, trackers, so it knows where the knee is. And then we check all the points so we know exactly where to make the cut. Now this is going to correct your bone and soft tissue at the same time. It also makes sure that your alignment's good. And that's within a half a degree. It also makes sure your positioning is good on the implant. So the robotic arm does not come in and do the whole surgery. That'd be a lot easier for me if it did. But I still have to make the cuts. I still have to do the surgery. I still have to know what's going on as far as the soft tissue. So I think for my career, I'll still have a job. Someday down the road, they may make it so the robots can do everything. Right now, it's just a guide, and it gives you a lot of information during surgery. So the robotic arm will come in, it'll rest on the patient's femur or tibia and tell you exactly where to make the cut. All you have to do is put the saw blade through the cutting guide, and that's how you make the cut. So that's showing you the tibia. If we make those cuts, it shows us what the outcome is going to be. So when you look at this screen, it's very busy. So it can be narrowed down to just the 4 points where it says M and L. So you're looking at the medial side and the lateral side, and that's how you get your soft tissue balance. And you do that in extension with the leg perfectly 0 degrees and straight, and you do that at flexion at 90 degrees. So we can move the implant, rotate the implant to try to get those numbers to match so that you know you're perfectly balanced. If you're perfectly balanced, your implant's going to last longer. You're not putting more pressure on one side or the other. And for simple knees, it works very good. For complex knees, it's very good because it makes a complex knee very easy. So most cases we're 40 minutes on the tourniquet. Right now we have the same system down. We've probably been doing it for 5 years. So we've done, probably 600 or 700 robotic knees already. And when you make the cuts, you can also check the cuts. Is this what we planned on the computer? And you can see the green check marks. So every cut that we made is what we wanted. So, and again, those numbers are within 0.5 millimeter, which is very small, and 0.5 degree. So it's very accurate. So this patient, you can see the gapping in space. Now, before you may cut too much bone, and then you got a big space on that lateral side. But we corrected that patient from 3 degrees to 0, and you can see the spacing's even on both sides. And you check that in both flexion and extension. Now, some of the manual knees versus robotic, if you look at the outcomes, some of the range of motion and stuff is similar. So it's still critical for the patient to do their therapy, whether you do a manual knee or you do robotic. If you don't do your therapy, you're going to be stiff. So that's important from the patient side post-operatively. And it's usually a couple months of therapy to get your range of motion back. It can take a little bit longer depending on how stiff you are going into the surgery. The other thing that's critical too is the quad muscle. We don't change the quad muscle. So if it's weak going into surgery, it's going to be weak coming out. So a lot of people will do pre-therapy or get that quad strong before a surgery. Now, when they compared patients that had a manual knee on one side and robotic on the other, they all said they had improved joint perception. They were more satisfied with the robotic. They got to independent ambulation quicker. It was less painful because you're releasing less of the soft tissue, and it felt more natural compared to the manual knees. So they asked those patients, would you choose manual or robotic? And majority said I would choose robotic. Now, if you look at the studies, there's not a huge difference in range of motion. That's patient dependent. But I think people get their range of motion quicker. So here's an example of a patient that had a robotic knee. You can see the bones touching on the inside. If you look at the stats, now before we'd say, oh yeah, they're bow-legged. Now we say, okay, you're 11 degrees bow-legged. It's a varus deformity. That's bow-legged. And we can check that. So when we put the sensors in, we check every point on the knee so the robot knows exactly where your markers are. How much bone's lost on one side versus the other. So we do multiple points. That takes about 3 minutes to kind of register the knee. Then we put stress on the knee. The stress is in 9 degrees of flexion and 0. So depending, the numbers there are taking the space 5 millimeters versus 2.5. So definitely tighter on the lateral side. There's more room on the medial side because that cartilage is lost. That's why it says 5 on the medial side. That's what we got to kind of correct. So when the numbers come up, the blue numbers say how much space. So if you cut less bone, we're going to be equal. So you can see the 18.5, 18.5, 18.5. So that gives you your perfect balance. This is all done on the computer screen before the robot arm comes in to make the cut. So we can make adjustments. We can cut more tibia. We can cut less tibia, less femur. We can rotate the implant. We can do all that. And at the top right, it's telling you what size you're going to be. So 65 is the size of the femur. So this also shows the flexion, which we can change. Now, before surgery, they were 11 degrees of varus. Now they're 3.5 degrees of varus. And you can see that the balancing there at 0.5, 0.5, both numbers match. So that's a perfectly balanced knee. The other thing we're finding out, And this is going to get better as we go along. At some point, they may just have AI, you say balance the knee, and it'll probably make the corrections for you. Right now, we do it kind of on the computer screen. But the other thing to note is we did not take this patient from 11 degrees to 0 degrees. So traditional training, mechanical access, we got to get everybody to 0. Most people are not 0 degrees perfectly straight. So some people are born bow-legged, some people are a little knock-kneed. So we're finding out with the robotics that we don't necessarily have to correct the whole deformity. The leg feels, to the naked eye, you can't tell that it's not straight, but from the numbers, it says it's 3 degrees. So we try to keep it within that, 3 degrees one way or the other. We don't want to go too much of deformity. But that's kind of basically the robot becomes a more specialized for each patient because we can make those adjustments. Before we kind of just did it by feel. Now, and you can see the full range of motion, 145. That's basically the limits of the implant. So if you're wondering what range of motion you can get to, it's about 145. We try to get people to 120, 130. That way they're functional with everything. So again, that's therapy dependent and the patient's range of motion after. So therapy is very important. When you're asleep, it's easy to get to 145. When you wake up, kind of the muscles, everything kind of tightens up. So that's kind of what you're working through. So the patient's job is a lot harder than my job. My job's easy. So that's kind of the information. It tells you what sizes to use. It tells you we've kind of balanced that, and that's what the x-rays look like. You can see that knee looks pretty straight. But if you look at the robotics, it's 3.5 millimeters or 3.5 degrees. But that's perfectly balanced. Now, that's a total knee replacement. If you're only worn out in one compartment, you can possibly do a partial knee. So the partial knees, with the total knee, you're taking out your ACL. It feels a little bit different. Partial knee patients always say that it feels like their normal knee. Now, because you're only replacing one part of it, there's less pain, less blood loss, easier recovery. It's just a matter of who's the candidate. So when you look at a partial, you're just replacing the medial side typically. Sometimes you can do lateral. The key to success, I guess, is how much, you have to have all your ligaments, they have to be intact. Some people, the ACL is kind of torn. The kneecap arthritis is a big problem. So we see a lot of people with bone on bone on the medial side and underneath the kneecap. So if that's the case, you're probably better off doing the total knee. But when you look at this, you're leaving some cartilage behind. So down the road at 10, 20 years, there's a possibility that you may need a revision. So that's kind of what you have to decide with the patient. But it's a smaller incision, and you're just replacing that part. They are also coming out with a press fit instead of with the cement. So they're doing that with the partials as well. And you can see there 94% at 10 years are still in place. So at 20 years, you got about a 10% chance of revision. Now, some of the studies that are coming out on the total knees that are 40 years out, 88% are still in. So that's kind of what you have to decide, as far as partial versus total. All right, transitioning into surgical treatment of the hip. So most commonly, people get a total hip replacement. Previously, they had hip resurfacing where you just kind of cover the ball in the socket, but those are metal on metal, so those are kind of falling out of favor. And if you don't have much arthritis, you may have a labral tear or something like that. That can be addressed with arthroscopy. So there's options for that. Now, this patient had both total hips redone, and the goal of the hip replacement is to kind of get you back to the activities that you like to do. When you think of a hip versus a knee, a hip is a ball and socket. We're replacing it with the ball and socket. So a patient's function is very similar with the hip, and at about 6 months or a year, you may not know you had the hip done. I think in general, patients always know they had their knee done. It just feels a little bit different. It's metal and plastic, you can hear it. Now, this patient is about 2 days post-op, so we got her on the bike right away. I'm just kidding, that's a joke. So, same with the knee, especially since we don't use cement in the hips. It takes about 6 to 8 weeks for the bone to stick to the metal. So we do use a muscle-sparing approach where we don't cut the tendons, but you still have to have the bone heal. So you really don't want to do anything too crazy in that first 2 months. You want it to heal. She's probably 4 months out after that, back on the bike. Now, the other thing to note would be the surface. So most people are using a ceramic head on a plastic liner. And the reason for that, we had metal on metal. Originally, it was metal on polyethylene, and the metal heads would kind of wear out the plastic. So over time, you'd worry about the plastic wearing out. So the engineers thought, well, if we do metal on metal, there's no plastic to wear out, it'll last forever. So that was great in the lab, but when we started putting them in humans, they started failing because of the metal particles. So the metal particles caused damage around the hip. They caused damage. They got in the bloodstream. They got kidney damage. So a lot of those metal on metal hips got recalled. And then, well, let's not do metal. Let's do ceramic on ceramic. So ceramic on ceramic are the ones that squeaked. So you could actually hear somebody walking with the ceramic on ceramic. So the other thing to note as far as materials, the other thing to note is what approach is the surgeon using. And all our hips are minimally invasive, very small incision. But you can see the different bearing surfaces. The top right's the ceramic on ceramic. And then they had the metal liner, metal head. And then now you can do metal head, ceramic head on a polyethylene liner. The cup, which is titanium, and the stem is titanium. Those both stay the same. So it's just a matter of what you're going to use for the liner and the femoral head. So the metal on metal ones got recalled because there was a lot of edge loading. The heads were a lot bigger. They put pressure on the side of the cup. Those are probably 10 years ago or 10, 15 years ago. So we're seeing some revisions. Usually if somebody has one and they did fine, they're okay. It's usually within the first couple years. But if you do have metal on metal, you do want to check it periodically. So metal on polyethylene is traditionally the longest track record. The disadvantage is the metal head compared to the ceramic head. The metal head is a little bit rougher. So over time, it can wear out the plastic. And then ceramic on ceramic, when they originally came out, they were a little bit more brittle, so they could fracture. We don't really see that anymore because they make them a lot better. And the problem with that is they squeaked. So what's the best of both? Using the polyethylene liner and the ceramic head. The studies that are, 21 years out have very little wear on them. So we think those ones are the ones that are going to last 40 or 50 years. Nobody's going to tell you that, but that's what we're thinking. So there's different shapes to the stem depending on what your femur looks like. All the stems will have a coating on them. That rough coating is where the bone sticks to. So we're talking about that 6 to 8 weeks to heal. That's what you're talking about. You don't want that stem moving or sinking while it's healing. So on both the cups and the stem will have that rough surface. So the cup will grow into the bone, and then you put the ceramic head. The ceramic heads and have different sizes too. So you can put a short neck length or a long neck length depending on the tissue tension. So that's kind of what it looks like on the x-ray. And again, you're replacing ball and socket with the ball and socket. So it feels very similar. Patients tend to have less pain than a total knee as well. And the joint's nice and smooth. So you're going from bone on bone to nice and smooth joint. You still have the surgical pain from putting the parts in there. Now, some of the stuff we saw in the past with the polyethylenes, they've kind of fixed all that. But the polyethylenes had problems with the packaging or oxidation. So now on some of them, we put vitamin E in there to prevent that. This study is probably 25 years old. So we don't see that as much that we did before. So if the plastic wears out, it's usually past 20 years old. So a hip replacement, the other thing to note is, leg length. So we measure that in the operating room to make sure we didn't make you too long. If you make a hip too short, the muscle tension is not going to be right and the hip will be unstable. So you have to get the tissue tension right and the leg length. So we're just trying to recreate your anatomy. Now, traditionally, most hips were done with the posterior approach, and some surgeons still use the posterior approach that's coming behind the femur. You cut through some of the tissue there, like the piriformis and stuff, so they have a slightly higher risk of dislocation. So a lot of people have switched to the anterior approach where you don't cut the muscle. So you can come in the front. You can see where that green square is. And there's a yellow nerve there. We cheat our incision more lateral to avoid that nerve. That's the lateral femoral cutaneous nerve, and it can cause pain down the thigh on the lateral side of the femur. When they originally described the anterior approach, that was about 20% of patients had that pain. We don't really see it because we cheat our incision a little bit more lateral to avoid that nerve. So we're going in front of the gluteal muscles to get to the hip, and that's the anterior approach. So we try to leave that muscle and tendon intact without any damage. So we're sneaking right across the front. So basically, we cut the capsule. We do repair the capsule when we get out, but that's how we're getting access to the hip. Now, you can do the anterior approach, You can do the anterior approach with the patient laying flat. So flat, the medical term is supine. So when they say anterior supine intramuscular, that's what they're talking about. So the good thing about that is when you're flat, we can check the other leg lengths. We can compare them. And we can also bring in x-ray a lot easier than when we used to do them lateral. Posterior approach, some people have restrictions for life. The dislocation rate is slightly higher than anterior approach. And then I think because of that, some surgeons will make the leg a little bit longer than it should be because it's hard to check the leg length when you're on your side. And if it's tighter, then it's not going to dislocate. So that's kind of what you have to worry about with the posterior approach. And again, those numbers are pretty small. So that's showing you the piriformis in the back. It's right by kind of the sciatic nerve. We do try to repair the piriformis if you come in the back, but usually it doesn't heal very well. So most hips, 99% dislocate posteriorly if it's going to happen. So to avoid the posterior approach and the piriformis, some surgeons will use what's called the super path. You can see it's kind of complicated and you can't see very well. So I don't recommend that one. But the reason for that is they're trying to come above the piriformis tendon, but it's still a posterior approach. Now, there is a HANA table that's used for anterior supine total hips. The only issue with that is you kind of lock your feet into what looks like ski boots. You can rotate it. You can't really touch that because it's not sterile, so somebody in the room has to do it. Usually the nurse in the room kind of rotates it. I don't like having the feet locked in because I can't check the leg length as good or the tissue tension as good. So basically they're doing the hip, checking with the x-rays and say it looks pretty similar to the previous one, but you don't necessarily check the tension as much. And there was some risk of fracture with the boots if you rotate somebody too much. Very low risk, but because of all those reasons, I don't really use the HANA table. I just use a regular operating room table, and we just drop the foot down. And we've been able to be very successful with that. So we're not cutting any tendons or muscle. We use a regular OR table. We make it slightly more lateral to avoid that nerve. When the patient's supine, we can check full range of motion to make sure that the hip's not popping out. So we put in the trials, we check the range of motion. As long as it's stable, the tension's good, the x-rays look good, then we put the real parts in. So less risk of fracture with not using the HANA table. Now the other thing too, when you do a posterior approach, you kind of rotate the leg until the hip pops out, and then you take the head off. So with this, you just cut the neck, and we can just gently get the head out. There's some reports where if you dislocate the hip kind of violently, you could stretch the nerves or the muscles. So we don't, what they call surgically dislocate the hip to prevent any of that. So cover your eyes if you don't want to see any surgical incisions. But you can see, you can compare both legs. You can move both legs. We're checking the length with both ones. We don't cut any muscles. We do repair the capsule. And I think not cutting the muscles and tendons has led to patients getting off the walker and cane way sooner than what we used to do. And then if we do a revision or something that we need a little bit more exposure, you can extend this incision because our incision is a little bit more lateral. But that does help with a faster recovery. And there's other things you can use with the x-ray to kind of confirm, leg length similar to the robotics, where it can check within millimeters how good the length is. Now, some of the complications we went over, dislocations, very low with the anterior approach. Infection, we give you antibiotics before and after surgery. Antibiotics when you go to the dentist because you don't want any bacteria in your mouth getting in the bloodstream. Blood clots is something that we do see. We've gone through, using really strong blood thinners or shots in the belly. That was Lovenox. There's Eliquis and Xarelto. If you're on some of that for your heart, we just keep you on that after surgery. If you're not and you're healthy and you have no history of blood clots, the current recommendation is just a baby aspirin twice a day. And you do that for 4 weeks. So leg length we talked about, we try to keep it even. You can't really change the leg length with the knee because those ligaments on the side prevent that. So leg length is more of an issue with hips. And then a lot of the medical complications, we want to make sure we address those before surgery, not during or after. So if somebody has a cardiologist, we make sure that it's safe to do the anesthesia and all that stuff. Try to find that stuff before. And you're surprised at what we find. We get pre-op labs and the hemoglobin's low and they got a stomach ulcer they didn't know about. So we do see a lot of that. So that's all part of the clearance. So there's been a shift too, as far as, total joints from a insurance standpoint or Medicare standpoint, as far as it's now just an observation procedure. Before it was an inpatient. When I was in residency, we kept people at least 3 midnights, in the hospital. They didn't have the nerve blocks at that time. They had to give them a ton of narcotics. They didn't get them up moving, so all that's kind of changed to where, you can see the surgery center. Most of our cases are done here and patients go home the same day. So anesthesia has helped a ton with that. And then we use a combination of, multimodal pain management, where you're using different medications besides the narcotics to get people moving. I think in the beginning, if you move too much, you can get a lot more swelling. So you got to kind of find that balance. If you don't move at all, then you worry about the blood clots. So physical therapy is definitely critical for knees. The hips, not as much. The hips mostly just walking. But we try to keep people on the walker, the cane, just so you don't fall in that initial period. You can get off them as quick as you're stable walking, but to be safe, we kind of err on the side of caution. We don't want people falling after surgery. An average healing time is 2 to 3 months. We have patients that are, 4 weeks out that you didn't really know they had surgery, but not every patient is like that. So I don't like telling people you're going to be good in 4 weeks. And then if they're not, then, so average is about 2 to 3 months. Everybody's a little bit different. I think the people that do the best are, in shape, their muscles are good before surgery. It's easier recovery for them. If you come in a wheelchair, your muscles are kind of atrophied. Those are the ones that do have to recover longer. Because once you have the surgery, especially with the knee, we're just covering the cartilage. We're not doing anything to the muscles. So if your muscles have to build up, that's why I think people say, it took me 6 months, it took me a year to kind of get back to normal. Now, a quick tidbit on shoulder arthritis. We do shoulder replacements as well. There's 2 different type of replacements. One would be an anatomic shoulder. The other one is a reverse total shoulder. And that all depends on how good the rotator cuff is. So both of them have arthritis, and you can see the bones touching there. The one on the right, you can see the bones touching the scapular bone above, which is called the acromion. That means that there's no rotator cuff holding that humeral head down. So if there's no rotator cuff, we do the reverse shoulder. So this would be an anatomic shoulder, and we do kind of minimally invasive as far as the stem. We're not using those long stems anymore. So that's the ball where it normally is and the socket where it normally is, but it's just metal and plastic. When you do a reverse shoulder, the reason they call it a reverse is we're putting the ball on the opposite side. So the ball goes on the socket side and the socket goes on the arm side. And what that does is it brings the arm down so that the deltoid muscle can do all the lifting. That's kind of what the implant looks like. But if your deltoid's doing the lifting, you don't really care what the rotator cuff does. So the deltoid kind of takes over, but you're putting the shoulder in a better position for the deltoid to work. So before, we didn't really have a great option. Now these are about 15 years out. We have very good results. Before, you'd put in the regular shoulder if they had arthritis, and then they may not get much motion because they don't have a good rotator cuff. So where you do the surgery, obviously this is Performance Health Surgery Center. You can see the empty fields in the back. Those are all filled up with a bunch more buildings back there. So it's definitely growing out here. And then in the back, we have overnight rooms. There, you can stay 23 hours. Most patients want to get out of here and go home. But we have private rooms. We have a lot of recovery areas, depending on if you need a little bit more time to stay. But we kind of built it knowing that total joints are coming. They're going to be outpatient. And we did the same in the back. So we have 2 hospital-grade sterilizers. We have 2 of everything. So it takes a little bit of, to process multiple total joint trays. So on our busy days, we've done 10 in one day. So we usually do about 8. So we kind of flew through a lot of options there, both non-operative surgical options. If you want more personalized opinion, depending on what your x-rays look like, you can just have Sheila call you, leave that sheet for her. and she'll give you a call and we can get you in for x-rays, etc. But I do recommend a fellowship-trained joint surgeon to do your replacements, and a couple of the websites. And then Sheila's extension is at 9819. So we have a lot of phone options when you call in, but her extension is 9819 and she can get you in. So I appreciate everybody coming. Thank you very much for bearing through all that. If there's any questions, we can kind of open up the